Okay, so back when I was in PA school, one of my favorite rotations was actually my geriatrics rotation at the Long Island State Veterans Home. This was a chance to really see what medicine is about. And you got to understand that in these days, the elderly population, those who are over 65, is greater than it's ever been in the history of this country. Most of that is chalked up to the big population explosion after World War II, known as the baby boomer generation. And so with that, more and more of your patients out in the field are going to be elderly, and the elderly population has very specific needs and very specific presentations that somewhat deviate from standard textbook presentations of what you normally see out there in the field. So first thing to talk about in your geriatric patient is how the body tends to change over the course of time. So even though we define uh, elderly as over 65, it's usually around 60, early 60s, where the body goes through a period of what's called senescence, where the organ systems tend to start the process of shutting down. That doesn't mean people can't live long and healthy uh, beyond 60s, 70s, even 80s. My father is 82 years old. He still gets on his hands and knees and crawls on the floor with my kids whenever we come over to visit. I actually had an aunt who lived to be 103 years old, believe it or not. She passed away about 20 years ago. And I remember one of my earliest memories of what a crazy nut she was. In her 80s, she was about 80, at a family gathering, she put a pillow under her dress and told everybody that my dad's father, my grandfather, had knocked her up and that they had to marry her now. And it was just a whole big soap opera. So age does not necessarily define a person's lifestyle or activity of living. But anyway, as far as age-related physiologic changes go, no matter how young you are at heart, there's still some downward trends that are going to happen in the body's makeup. First is neurologic system. As we get older, neurons tend to atrophy. The space between neurons or nerve cells tends to increase, the synaptic space, making motor transmissions and signal transmissions less efficient. The whole nervous tissue of the brain itself tends to atrophy, lending itself to more increase in injuries like subdural hematomas. Nerve fibers tend to decrease and change in structure, tend to lose some of their connections. Dopamine level in the brain tends to deplete, somewhat leading to increased incidence of depression and loss of interest in things. Slowing of motor neuron conduction, which can make driving an issue as we get older. Alterations in the autonomic system and sleep patterns. Insomnia is very common in the elderly population. Overall slowed reaction time. That's why I say when the two people most commonly affected by subdural hematomas are the people that tend to be less able to protect themselves from reaction time from a fall. Cardiovascular changes that occur with aging include increased irritation of the myocardium. The myocardium is the heart muscle, which is supposed to contract smoothly and at the command of the SA node and the normal conduction pathways. As we get older, the myocardium tends to stretch out, wear out, and it's not uncommon for a cell here, a cell there to beat aberrantly outside of the normal conduction system, leading to what we call ectopic beats, or beats out of place. Increased risk of atrial fibrillation and arrhythmias. Atrial fibrillation, well, you know what ventricular fibrillation is, right? It's a rapid quivering contraction of the ventricles. But you can have a condition called atrial fibrillation where the atria themselves are quivering and beating anywhere from 150, 200, 300 times a minute. And that could be followed up with either a normal or a rapid ventricular response, leading to an irregular heartbeat. These situations predispose an individual to more incidents of stroke, fainting episodes, and things of that sort, and sudden cardiac death as well. Increased vascular resistance. Blood vessels tend to stiffen up with calcium deposits, leading to increased blood pressure, increased afterload on the heart, which can also lead to, over time, increased resistance and failure of the heart, leading to decreased cardiac output. Decreased arterial elasticity. Respiratory changes include decreased rib cage elasticity. Okay, think about how much less tidal volume an elderly person can get with just one good breath of air. Vital capacity and pulmonary blood flow decrease, making oxygen exchange less efficient. Decreasing cough reflex, decreased ability to get all the little dust particles and soot out of our airway that younger, healthy people never even think about. Decreased ciliary response, and can even be more enhanced if they've smoked for any time in their life, leading to increased mucus production, stagnant mucus flow in the respiratory passages, and more chances for bacterial overgrowth and pneumonia. The renal system goes through changes as well. You have decreased glomerular filtration rate and creatine clearance. The glomerulus is the functional unit of the kidney. It's where all the filtration occurs and exchange of electrolytes occurs and reabsorption of water occurs. As you know, the kidneys are very responsible for excreting a lot of toxins out of the system. Many drugs that a person takes, medications, once they've reached their therapeutic effect, are eliminated through the renal system. And as the renal system decreases, the chance for backup of those drugs and toxicity from those drugs increases. Changes in response to sodium intake, which can inability to filter out excess sodium, can cause increases in blood pressure. Muscle hypertrophy in the urethra and bladder, leading to urinary retention. Urinary retention can lead to urinary tract infections. Urinary tract infections can lead to a whole host of problems, including mental status changes and sepsis. And decreased ability to concentrate urine, which can lead to electrolyte imbalances, which can lead to all sorts of metabolic abnormalities. In the gastrointestinal system, decreased number of taste buds and capability to taste. So decreasing the pleasure sensation from eating. Decreased peristalsis, decreased ability to move food throughout the GI tract. Diminished secretions of pepsin and acid in the stomach, as well as hepatic and pancreatic enzymes that lead to an incomplete breakdown of nutrients in the digestive system, incomplete absorption of proper nutrients, and incomplete destruction of pathogens in food as well. Now, one of the things that's very interesting in the elderly population is the fact that they can present very out of textbook to common medical ailments, things that we've learned about so far, the textbook presentations of myocardial infarction, the textbook presentations of pneumonia, of diabetic emergencies, presentations to trauma, don't always present typically in your elderly patients. There's a number of reasons for that. For one thing, your elderly patient may kind of blow off their symptoms thinking that it's just a normal reaction to aging. Decreased sensory perception may make it difficult for them to even know what's going on. Sometimes the overabundance of medications that they're on can blunt symptoms of severe disease. And just the fact that as we get older, our decreased physiologic reserve makes autonomic responses to disease processes less efficient. So, for example, an acute abdomen, such as small bowel obstruction or appendicitis or whatever you can think of, usually results with constipation and decreased appetite rather than severe pain, like you would see somebody who's doubled over. A pneumonia, where you would typically think of somebody coughing, short of breath, and febrile, may present with a dry cough rather than a fever, and maybe vague chest pain. Depression in the elderly usually presents itself with more agitation and irritability rather than dysphoria or sadness or melancholy. With falls, and falls are a big issue with the elderly, uh, one of your biggest complication of falls is the onset of pneumonia due to decreased activity, so infections. Or infections themselves can present in the patient falling rather than them elevating their fevers or elevating their white blood cell count. Sepsis is not an uncommon situation in the elderly, and we think of sepsis, full body infection, we think of decreased mental status, high fever, maybe signs of shock, all system-wide shutdown. But in the elderly, it's just sometimes a matter of generalized weakness and, quote, grandpa is just not acting like himself. You'll hear that a lot when you're out there, and family members often can't really get any more specific than that. However, that's a red flag that something is going on. Myocardial infarction, MI, cardiac, with dyspnea and confusion rather than chest pain. I think during our cardiac lecture, I spoke about a patient I had who was in her 80s whose only complaint was breaking out into a cold sweat. Never had chest pain, never had shortness of breath, thought she was coming down with the flu, yet ruled in for myocardial infarction. So you want to keep your level of suspicion up there. You want to have a very low threshold for recommending treatment and transport to the hospital. By whatever means you can to convince your elderly, do so. And convincing them means communicating with your patient. And communicating with the elderly can take time and it can take patience. You may have to overcome barriers such as sensory deterioration. If they can't physically see you, you may want to stay close, or you want to offer a reassuring touch. If they're hearing impaired, shouting at them usually does not make you any more comprehensible. Instead, you want to try to talk as slowly and as clearly as possible. If there is hearing loss, do they have a hearing aid? Did they have it in their ear? Can somebody go get it? Patients with dentures usually have difficulty speaking if their dentures are loose or missing, or maybe previous medical problems such as a previous stroke where they have difficulty articulating to begin with. All in all, it's very important for you to maintain a gentle touch, a professional touch, and have a lot of patience. When interviewing an elderly patient, one of the big drawbacks is quite often the emergency at hand is not necessarily what they'll be complaining of. Family member may notice that they started shaking, turning blue, and having a seizure, and by the time you get there, the patient's only complaint is their lower back pain that they've had for the last 6 years, and they may have no other issues with that. Sometimes as patients get older, you try to get a focused history and they may go off on tangents about other things, which kind of makes the interview process a little more difficult. So with that, it's a real art to try to reel them back in and bring it to the issue at hand without being rude and without being abrupt. So when you're assessing your geriatric patient, just like everything, always start with your scene size up. Are there any physical hazards that could produce injuries? So when you're talking about your elderly, sometimes you're not so much of the lifesaver first responder as you are the first eyes and ears of the social worker to make sure this person's in safe living condition. I mean, are there like tripping hazards, like stretched out cords or slippery throw rugs in the house? Are there broken steps that are a falling hazard, exposed wires, anything? These are things that we just want to observe during our scene size up and our general impression to see if there's any environmental situations that may contribute to this person's illness or injury or potential safety hazards. Is the environment well ordered or in disarray? Are the medications organized and current? And we'll talk a little bit about issues with medications in the elderly in a few moments. Are the surroundings sanitary? Is there laundry all over the place that hasn't been done? Is there half-eaten food out on the table? What's the temperature of the home? Are they using their ovens as a home heating device? Not only is that a social situation, that's a hazard situation as well. So going back to the airway and breathing, assessing their airway and breathing. Well, the airway and breathing may be affected by things that are out of your control. Stiffness in the neck, dentures that cause blockage, previous stroke, trying to open up the airway in somebody who's got a very stiff neck and has a very hyper, what's called kyphotic curve, or hunchback even, because as they get older, the spine tends to decompress. These can all be things that can affect your management of the airway. Circulation may be affected by things like irregular heart rates. You may have a little difficult time assessing a pulse that's beating irregularly irregular. If anybody doesn't remember what irregularly irregular means, that's a pulse that's just beating haphazardly with no rhyme or reason, like ba 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 ba, as opposed to regularly irregular, where you have a regular underlying rhythm, but every now and then a skipped beat. So like ba 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 ba. So you kind of pick up on that. It's easier to visualize if you see an EKG, but we generally don't have that available to us at the BLS level. You also got to be very gentle in handling and extricating and lifting and moving a patient. As we get older, the integumentary system breaks down. Collagen in the skin breaks down, leading to very, very delicate, fragile, gentle skin that can easily tear like tissue paper. And a lot of times these skin tears are very difficult to repair in the hospital as well. If they're on blood thinners, they may bruise very easily, even with the slightest bit of compression. And sometimes clinicians in the hospital look at these bruises from normal handling and they sometimes become suspicious for abuse. So take care. Take care of how you transport them as well. As I said before, listen patiently when they're speaking slowly. Try not to rush to conclusions. Try not to finish the sentences if you can. Big pet peeve of mine personally is when EMTs or medics start carrying patients out of the hallway without any real emergent or urgent issues going on, but leave them half exposed, taking them out in their nightgowns with any blanket around them or robe around them. Unless there's a real dire issue, like a patient is crashing, take time to protect the patient's modesty. It's a matter of respect, and just think if it was your own grandmother or mother. Take extra time to pad or cushion unusual body curves. So you've all had practice lifting and moving on the scoop, on the stretcher, and most of you are young and most of your spines are in shape. Well, if the person has abnormal contractures or abnormal curvatures as a process of aging, such as you can't lie them down flat on the backboard or the scoop, you have to improvise and you have to compensate, and you have to pad those areas with sheets or towels or blankets or whatever, or pillows or whatever you can use to get the job done. You can get the job done safely. So what are some common issues? Maybe necessarily medical issues, but social issues and medical issues as well with elderly patients. Well, one of the big issues is that of pharmacology, of medications. Now, one problem with medications in the elderly is cost. All right, so think about it. If medication is $60 and they have to pay $10 copay for each medication each month, and then on 6 or 7 different medications, you can see how those bills can rack up. Another issue is something called polypharmacy, where your patient may go to her primary care doctor and be on 3 or 4 different medications for all different ailments, then see a specialist, such as an orthopedic or a cardiologist, and be put on another couple of medications. And then maybe go to an ER, an emergency room, or urgent care center that doesn't have any records on them, and they may be put on some type of antibiotic or anti-inflammatory that has interactions with the previous medications but nobody knows about. It's less common these days because of electronic charting and the ability to flag these things, but it's still an issue when you have all these different medications uh, interacting with each other. They're one of the biggest causes of premature death in the elderly population is adverse medication reactions. Antibiotics and antidepressants, for example, non-steroidal anti-inflammatories, and heart medicines, just to name a few. So it's just something to think about. And so when you're on the scene, people in the street may tell you otherwise, but especially if the patient is in some sense of urgent condition there, just grab the medications, put them in a bag, and let them sort them out in the emergency room. Don't waste time writing down uh, each and every medication because it'll take forever. And also what a big problem is most EMTs, when they write the medications down, they don't bother writing down the dosage or the amount of times a day, the frequency, and that's really important information. And if you're not going to write that information down, then why even bother? Because it's incomplete. Another problem with pharmacology is patients' compliance with medication. So, for example, to say they take something like a blood pressure medication, but they only take it when their blood pressure is high. Well, how do you know your blood pressure is high? Well, because I usually feel sick when the blood pressure is high. But a lot of times you don't feel sick when the blood pressure is high. And if they don't take the blood pressure medicine on a regular basis, they're putting themselves at risk for stroke. Psychiatric medications like antidepressants, people think sometimes they work on demand like painkillers, and it usually takes several weeks of being on these medications to actually see their therapeutic effect. And a lot of times people will stop taking these medications before the therapeutic effect kicks in because the side effect is intolerable to them. So, as we said, complaints of shortness of breath may or may not be associated with chest pain. Things such as asthma, emphysema, heart failure. Remember, heart failure is not the same thing as a heart attack. These are all causes of shortness of breath that will not usually result in chest pain. And myocardial infarction as well. I mean, again, you got to really have a high index of suspicion. Just something like general weakness or just atraumatic left arm pain or sweating or even just nausea with no vomiting and no other GI symptoms should always raise your suspicion for myocardial infarction. Now, at the EMT level, we do have the ability to do 12-lead EKGs, but that's more to facilitate transportation decision. EKG does not definitively diagnose whether a person's having a myocardial infarction, and it definitely does not rule it out. You can have a completely normal appearing EKG, and the blood work 20 minutes later will demonstrate that the heart is actually infarcting. So it's a good tool, but it's not perfect. Abdominal pain. You always, like I said, minor abdominal issues usually don't present with pain. When you have an elderly person with severe abdominal pain, you've got to think of things like an aneurysm, like their lower aorta about to burst, causing severe hypovolemia. Usually they'll complain of a tearing type sensation. Acute bowel obstruction. They won't tell you that they're unable to move their bowels. They'll probably just present with a lot of pain and maybe some vomiting. What are the risk factors for acute bowel obstruction, usually surgery, previous surgery in the past, or undiagnosed hernias. Uh, a lot of times your only complaint is just weak and out of it, weak and malaise. Maybe a sign of underlying problem could be so many different things. Could be myocardial infarction, could be kidney shutdown, could be electrolyte imbalance, could be depression, uh, new onset. Depression in the elderly is a very unrecognized or underappreciated condition, and probably underaddressed as well. Falls should never, never accept an RMA, or I should say encourage an RMA for any elderly patient who has fallen. Uh, Even what seems to be non-significant falls, 25% of the time will result in death within a year. Impact on lifestyle can be devastating. Circumstances often linked to serious disorders. You got to really look at the circumstances behind the fall. If it's truly a mechanical fall, um, they slipped on a throw rug, they tripped on an uneven sidewalk, a full physical exam reveals no obvious injuries whatsoever, use your judgment. But just remember, there are times, especially in the elderly, when a simple fall, just the force, the acceleration, deceleration, can cause internal injuries without any external indicators. So please have a low threshold. Many elderly are deathly afraid of going to the hospital, and for probably good reasons. For one thing, if somebody's really old and maybe in their 90s or so, when they grew up, they probably remember the time where a hospital was not a place where you would go to get better. Hospitals back in the early days were places that the well-being went to go to die. Most hospitals were more like wards for the deathly ill, just for custodial purposes. And those impressions are hard to shake. Also, your elderly, they don't want to be, they want to lose control over their own circumstances. A person who's been independent for 70 years or so, all of a sudden has somebody else in charge of them. They may feel that they never go home again. Separation from loved ones, even separation from their pets is a big thing. Interesting thing, I had a patient in the ER years ago in Manhattan. He's mid-80s, sweetest guy in the world. He actually used to play the part of Mr. Clean in the commercials for that product in the 1960s. It's an interesting story. Sweet guy, had a pretty bad pneumonia. Needed to be admitted to the hospital, but he absolutely refused because he had a dog at home and nobody to watch his dog. And I'm sure if you're an animal lover, a dog lover, if you have even cat lover, and you know the situation, you can empathize. So what can we do to account for that? Can we involve the assistance of any neighbors? Can we call a relative? These are hypothetical questions that we need to ask ourselves. We mentioned the copays of medications. Just 5 medications could be $50 out of a pocket in just 1 month. Think about the cost of hospitalizations. Medicare is the insurance, default insurance of most elderly people. If they don't have supplemental insurance, Medicare only covers 80% of medical bills. Now, I know from personal experience, when I had surgery years ago to remove a benign tumor, the whole cost of the surgery and everything combined was about $50,000. What's 20% of 50,000? Well, that's another 10,000 out of pocket. Do most elderly people have that stored in the bank? Probably not. And consider the possibility that an elderly patient might be understating their medical complaints, maybe blowing it off or in denial. Don't outright accuse them of denial, but try to be as persuasive as you can. Now, in New York State, you are a mandated reporter of suspected child abuse. There is no law, there is no regulation, unfortunately, for suspected elder abuse. That doesn't mean it's not an important thing to look for. And quite often, the perpetrator of elder abuse tends to be the closest caretaker, a family member, but it also could be a custodial agent like a nursing home attendee, or or maybe somebody not related at all, friends of the family, neighbors, but it's usually somebody close. Um, Now we know mostly the obvious signs of physical abuse: overly hitting, pushing, shoving, ignoring physical needs, neglect, not seeing to the needs of this person that you're responsible for is also a form of abuse. Psychological abuse can occur as well. Belittling the person, telling them they're worthless, threatening them, insults, shutting them out from the world, putting them in social isolation. Financial abuse as well also includes coercing the individual to sign over financial documents, money, stealing out of their finances. You also have things like sexual abuse that occur, and that happens as well. Um, Usually, and if you don't ask, if you don't assess, if you don't look for the clues, this person can face a very quick downward spiral in well-being and decompensation, and quite often leads to an early death that could have been avoided. So that's really the quick spiel on elderly geriatrics. Let's just go over a couple of points just to review. So as an adult ages, the body experiences changes that cause disease processes to take place: a decrease in compensatory ability, an increase in blood pressure, inability to maintain homeostasis. The best answer is a decreased compensatory ability. Not every elderly patient has high blood pressure. Many actually have normal blood pressure, even low blood pressure. But a normal consequence of aging is decreased compensatory ability due to all those physiologic changes that we talked about. The elderly patient will most likely experience what as he or she continues to age? And the answer would be a decreased intestinal tract movement, or decreased peristalsis. Of the older patients seen in the emergency department due to a fall, how many will die, or what percentage will die in 1 year? The answer is 25%. 25%. And when interviewing an elderly patient, the EMT can increase the accuracy of the information he or she gains by allowing sufficient time for the patient to answer. And last point here, an elderly patient who's experienced a myocardial infarction is more likely to complain of which of the following symptoms than a younger patient would? And the answer there would be shortness of breath without chest pain. Okay, so do we have any questions before we take a break? All right, guys, the time now here that I've got on my watch is 7:17. We will pick up at 7:27. See you then. All right, guys. So we're going to start up again. And right now we're going to be talking about Chapter 35, the emergencies for patients with special challenges. So when I took my EMT class 1.5 and 3/4 years ago, I was taught about patients with diabetes. I was taught about patients with heart disease and patients with um, psychiatric disorders, and I was taught about patients who were involved in motor vehicles and all that stuff and gunshots, but wasn't never taught about patients who had peculiar needs or peculiar situations, which we don't often see out in the public, although we probably do more so than we realize. And I'd say I was definitely unprepared when I dealt with my first patient who was on a ventilator, or when I dealt with my first patient that had a Foley catheter, or when I dealt with my first patient going to dialysis, and I had no clue what to do for these patients. My first job in EMS was a relatively boring one, as most people's are, who was doing medical transports for a private company. Um, wasn't the exciting 911 that you'd expect it to be. So this was a chance where you saw most of these chronically ill people with certain situations, certain devices that you had to become familiar with. And so it's good that the curriculum is kind of addressing these things now, just so it's not so much of a shock. Not that these things are really shocking, but these situations you can be a little familiar with when you come across them when you're finally out there, and that will be soon. So, when you use the term disability, it's a condition that interferes with the ability to engage in activities of daily living. It could be developmental, could be physical, it could be something somebody's born with, something congenital, or it could be something that's acquired. Um, could be a result of traumatic injury or medical condition. Um, anything you can think of: multiple sclerosis, which is a central nervous system disease; Parkinson's disease, which is acquired over time; stroke; traumatic brain injury; spinal cord injury. There was a time when most patients with these conditions were confined to institutions or long-term living facilities. With advanced technology the way it is today, and advanced education and training, many patients with these conditions, as well as others, can live in their own homes with their families, when that was unheard of years ago, and live somewhat, maybe not independent, but codependent lives, and maybe even some productive lives as well. So we already talked about situation with the sight impaired and hearing impaired, and how sometimes you need to make accommodations. This EMT, for example, is allowing this sight impaired patient to feel his face so she can get an idea of who she's talking to. Now, I'm not saying that I encourage everybody to do that under every circumstance. It's a very personal thing you decide to do, and especially in today's day and age with what's going on with COVID, may not be so quick to do that, but just an idea that sometimes we need to go a little bit above and beyond our call of duty for those patients that don't really fit in the textbook presentations. So think of your patient who you're transporting that may be facing a terminal illness like end-stage cancer or kidney failure. I don't really know if I've ever seen anybody with Huntington's disease. Lou Gehrig's disease, amyotrophic lateral sclerosis. It's a horrible disease. It's very painful towards the end, where a person just basically loses function of all their motor neurons, but they still retain their sensory neurons. So they can't move, but they still feel a lot of pain. The great scientist Stephen Hawking, who's wheelchair bound, who passed away a few years ago, suffered from Lou Gehrig's disease. Uh, um, but some of the course of your interactions, you may be transporting people like this to the hospice, or from the hospital to long-term care facility, or discharging them from the hospital, long-term care facility, to home so they could die out in peace in their last few days. Well, think about how you would interact with someone in their family, this person who knows that they may have a few days or a few weeks to live. Um, they may be depending on technology right now to sustain life, like a ventilator, or to relieve pain. They may be on infused pain medications. What kind of advanced directives do they have? And it's important to understand what type of advanced directives we recognize as EMTs in New York State versus what they may have. And that may be something that needs to be confronted up front with the family or the sending staff so there's no miscommunications or misunderstandings. We're never told to deal how to deal with obese patients. Now, obesity is unfortunately in this day and age, as always has been, dealt with a lot of ridicule, a lot of um, abuse, verbal, mental, a lot of disdain. But obesity is definitely a medical problem, and it's listed in the medical literature as a disease. And it's a lot more of a result than just more calories going in that are getting burned up. Calorie in versus calorie out works well in physics and thermodynamics. It doesn't really work well in the realm of physiology. There's many other factors that contribute to obesity, some genetics, some long-term lineage, some hormonal issues, body type, mental issues as well. But the bottom line is that obesity does have an increase of multiple disease processes, especially heart disease and diabetes, as well as things like a respiratory failure and obstructive sleep apnea. And also, when you think about the issues involved in emergency transport of the obese, you know, um, you think about how you're going to transport or extricate this person who weighs 300, 400 pounds down 4 flights of stairs in a brownstone. You got to really kind of think about these things and plan for them ahead of time and drill and train as well. As anybody that lives in New York City knows, there is a severe homeless and poverty epidemic, if not over the country, definitely in New York City. Just take any walk down Times Square and you'll see what we're talking about. A big portion of the homeless population, unfortunately, consists of homeless veterans and the mentally ill as well. Usually, the mentally ill who years ago would have been uh, confined or living in mental health institutions um, are now on the street, either due to lack of resources, lack of oversight, uh, or lack of proper medical care in which they cannot properly treat for themselves. A lot of your homeless suffers from substance abuse problems, polysubstance abuse problem, alcohol, and illicit drug use. There is a high prevalence of tuberculosis in homeless shelters. You go up to Fort Washington shelter over by Presbyterian Hospital, Columbia Presbyterian, 168 and Broadway. There's a huge shelter there, multi-level, and it's just beaming with tuberculosis patients. And that's the one thing you should always think about. If you're getting called to a homeless shelter or an institution, uh, remember the telltale signs of active tuberculosis infection: fever, cough, night sweats, hemoptysis, unintentional weight loss, things of that sort. Autism, or I should say autism spectrum disorder, because autism is really just a catch-all phrase for a lot of situations that involve some developmental and communication delays in individuals. Um, you've probably seen some movies over the years like Rain Man and other things like that, which kind of depicts someone with autism, but no one characteristic fits all autism patients. People with autism are as individual as anybody else. Uh, Generally, the characteristics of autistic spectrum disorder are decreased ability to communicate, decreased ability to interact around the population, uh, a real adherence to routine, a real adherence to familiarity. Um, Now, you can have very highly functional autistic patients with things like Asperger's syndrome, for example, or you can have very, very um, developmentally impaired autistic patients, like individuals with Dravet syndrome, who their adult lives will usually never have the mental capacity greater than a 3-year-old. The spectrum is very variable, but uh, the ABCs of dealing with patients who have autism are basically being aware of the condition. Keep things as simple and basic as possible. Keep your voice as monotone and as level as possible. And think about safety. Dealt with patients with autism in the ER, in the urgent care. Most often, violence is not an issue, but fear in the autistic patient can invoke unintentional violence. So the more you can minimize that, the safer you can be. ENT must adapt approaches and strategies to patient. Uh, Maybe if you can engage the services or the aid of the family member to help you out. If you can demonstrate, almost like a child really, listening to lung sounds with your stethoscope on the caregiver first, then let the patient see what you're doing. Disruption of routines is not well tolerated by a patient. They like to be in their set routines. Communication may be challenging. They may not want to make eye contact. They may just nod or glance at you or give you very short answers. Escalations and meltdowns are tantrum-like behavior. They are known to occur. Um, you know, Bottom line is just try to do the best you can. Okay, so talking about that. Okay, so let's talk about patients who are on home medical devices. And again, where once a lot of times patients with a lot of different medical conditions would have been confined to custodial facilities, a lot more patients are living at home, living their lives where they previously couldn't. So this results, as what I was saying before, more conditions that the EMTs did not previously encounter. Calls may be for a problem with the patient's device, such as the bells and whistles going off, or a medical or traumatic problem unrelated to the device, but you still have to deal with the device as well. Uh, for example, you may have a patient who's on a home ventilator, and there could be a problem with the ventilator. It could be dislodged, it could be obstructed. Um, the ventilator itself may be mechanically failing. There could be a power failure. Um, and these could happen in any number of places. EMTs may respond to private residences, nursing homes, specialty rehab centers, special care facilities like VAs, anywhere really. The first line of defense is asking the patient and the family, are they familiar with this equipment and what's going on? Uh, Most of the times, patients in this situation have to be under the care of someone, whether it's a spouse, daughter, sibling, whatever, who is trained and very well knowledgeable in this equipment. Um, I'm not saying they necessarily need to be expert, but often they are on what's going on. They usually know what dials need to be set, which buttons need to be pushed. So if you're on the scene for a call where a ventilator, for example, may not be functioning properly, ask yourselves the following question. Is this problem with the device life-threatening? Do I have the knowledge to fix this problem? Probably not. Do I have the supplies needed to fix this problem? Is it within my protocols, within my medical control authorization? Sometimes, if you're really smart, if you're really on the money, if you're really crackerjack, uh, maybe medical control will let you do something like, like, uh, just clean out the ventilator and replace the plug or something like that. It really depends on how smart you are and how comfortable your medical director is with you. So, in any event, special concerns or patients with chronic disease may experience sudden worsening of the disease. So, for COPD, for example, we know that's a chronic thing that people have all the time. And then we've been going back and forth. Do you give this patient oxygen? Do you not give this patient oxygen? But just remember that patients can also develop an acute illness on top of that chronic disease, something we call acute on chronic. So why did they call? Because all of a sudden they're breathing from normal 20 times a minute to 30 times a minute. Now they are more blue in the face than ever. Now they can't catch their breath. It's important to address that. Going back to advanced medical devices. So some things to be familiar with. Home CPAP device. So CPAP is a device that continuously blows air, allows for positive pressure along with the inspiration and the expiration as well. And it's most commonly prescribed at home for people who suffer from obstructive sleep apnea. Uh, Obstructive sleep apnea is a condition where a person in their sleep may not completely wake up, but wake up from their deep sleep 20, 30 times a night because their breathing actually stops. They don't necessarily consciously notice it. Their spouse may notice it or their partner may notice it. But over the long term, it leads to long term health problems, hypertension, CHF, depression, uh, decreased immune function. And most of the times, the causes of this are anatomical. It's very common in obese. Your dad has it, Raymond? Yeah. So, does he suffer from complications from it? It's not uncommon, really. It's more common than people think. Obesity is a very common causative factor. Uh, okay, Raymond, you got my curiosity now. Your mom gets mad at him for having sleep apnea, or because she has to deal with that loud machine? Okay, or because he doesn't comply with the machine. That's usually the problem. Um, Weight reduction has been shown to help with sleep apnea, but some people are just anatomically prone to it. People with, you can see this patient has probably a short chin, large tongue in proportion to the airway, can leave people uh, large tonsils, and some people are just neurologically prone to it as well. This machine helps prevent those sudden episodes of apnea, allowing for a better night's sleep, less disruptions in ventilations, and overall better quality of life. I honestly don't myself see how I could ever get used to something like this strapped on my head, blowing in my face all night long. But I guess people adapt to it over time. So if you get a call for this person, it could be something completely unrelated to the device. It may be in their best interest to transport the device with them because they may not have a similar device in the hospital they're going to or something that meets their specific needs. So do the right thing and bring it with them as long as that's what they want, but I would probably recommend it. Quite often, you'll see somebody with a tracheostomy tube. This is a tube that basically bypasses the naso and the oropharynx um, and seals off the trachea from the food canal. And there's a whole host of reasons why somebody may have one of these, but most often is because they have some condition, some neuromuscular condition like MS or stroke, where they lose their ability to swallow, uh, to isolate their windpipe and their airway from the digestive system. So aspiration becomes a big problem, big issue. So basically, they seal off the trachea from the top, and person breathes through this opening called a stoma, which I believe we talked about before. And that stoma is kept open through this device. It looks just like the end of an endotracheal tube, really, called the tracheostomy. And it fits in there. It can be removed. It's usually stitched in or mounted in, but it can be usually be removed. And they usually wound up either breathing spontaneously on it, or sometimes they're intermittently put on a ventilator, or sometimes they just have a ring of oxygen around it and they receive blow-by oxygen passively. But it's the big problem with this device is that it's, regardless of how life-saving it is, it's still a foreign object in the body, and the body doesn't like foreign objects. So what does the body tend to do? It tends to initiate an inflammatory response. It tends to produce mucus. Mucus tends to get trapped up here a lot, and that's the biggest problem with these devices, is that they need to be cleaned out and suctioned and quite often replaced. If this device is hooked up to a ventilator, and the ventilator is failing, or if this person needs to be transported and the ventilator can't be transported with them, it's very simple to just take the mask off of your BVM and attach it to the end here. The fittings are universal, and just take over this person's ventilations for them. And you can really just get a feel for how well you're ventilating them. If they look like they're comfortable, you're probably doing a good job. If they look like they're anxious, you may not be ventilating enough, or you may be ventilating too much, and that's something you definitely got to be careful with. And it may be incumbent upon you to take your suction equipment and get that suction, all that goop and mucus out of that airway. It's generally recommended using a soft suction catheter and inserting it just as far as it'll go in, and then suction on the way out. As I said, a lot of people live at home on home ventilators. You're not just seeing them in the hospital on the respiratory units anymore. And a lot of times they're quite portable. They can be taken with the patient from time to time if they have a clinic appointment or a therapy appointment or something of that sort. And they're designed to really go with and assist the patient's own spontaneous ventilation. They're very intricate machines. They can completely take over a person's ventilations, or they could sense the person's own spontaneous ventilation and give a breath when needed, or give a breath at a prescribed rate. But you see, it's a little complicated. You have the machine, and then you have the tubes. You have one inspiratory tube, one expiratory tube. The worst case scenario, like I said, you can take the tube off and replace with a BVM and facilitate transport. Well, the big problems with these comes down to really a few things. If the alarm starts going off and the device doesn't appear to be working, one of about four things can be happening. So for one thing, the tube dislodged. It fell off the tracheostomy site for whatever reason. Well, if that happens, the machine is going to sense it. It's going to sense that lack of resistance, and it's going to send off the bells and whistles. So that's the first thing you should look for. Did this thing pop off? And if it did, just pop it back on. Is there an obstruction? Is there something blocking the flow of air to and from the trachea? So one of the most, well, the most common cause of obstruction is a mucus plug. Like I said, those things are constantly built with mucus. So the first thing we want to do is disconnect it and suction out that tracheostomy as well as we can. Another cause of obstruction is usually from this hosing getting kinked and being physically blocked. So that's something you want to check for as well. You want to go through the hosing with your two hands and look for it and trace it all the way back to the machine. Another thing that may cause a signal or alarm to go off on these machines is if this person suddenly developed a pneumothorax. And a pneumothorax is always a potential complication when you're inducing positive pressure ventilation. As good as these machines are, nothing is as good as the patient's own brain stimulating their own spontaneous respirations. But if the person starts developing a pneumothorax, that machine is going to sense the increased resistance, the increased pressure to ventilation, and the machines are going to go off. Well, how do you figure a pneumothorax? Well, you assess your patient. You look for the signs. You listen for lung sounds. You look for the tracheal deviation. And then you get them out of there as fast as possible. And then last but not least, maybe you have equipment failure. Maybe the machine itself is broken or the power is shot or whatever. In which case, again, just put the BVM and do the ventilating yourself. 1 breath every 5 to 6 in the adult, 3 to 5 in the child. It's really not that complicated. So I do believe we spoke about this during cardiac emergencies. Somebody may have an implanted pacemaker or internal automatic cardiac defibrillator. A pacemaker is a device that gives a prescribed electrical jolt to the heart when it's not beating fast enough. You know that the normal uh, rhythm or normal rate of the heart to create an adequate cardiac output is about 60 to 100 beats per minute, give or take, in the average healthy adult. Well, an adult has a problem with that conduction system, and that SA node is not firing properly. We know that the AV node can take over at some point, but if the AV node can't fire from 40 to 60, the ventricles will take over. But the ventricles only have an intrinsic firing rate of about 20 to 40, and that may not be enough to provide the cardiac output that that patient needs to fulfill their daily activities. So the pacemaker is implanted, and there are many different types of pacemakers. Some will fire automatically, at a pre-prescribed rate. Some are demand pacemakers. Some will sense the heart and will shock it only when it goes below a certain rate. Some will sense the demand for extra beats and beat a little faster accordingly. Usually the biggest problem with pacemakers is that after about, if they're not firing, it's usually because the battery is starting to die out. But these batteries tend to last a long time. I think they last about 20 to 30 years these days. You do know that with a pacemaker, you'll probably see it implanted. You'll see a bulge sticking out of their chest wall that kind of looks like the size of a stopwatch. And you know the issue with defibrillation is that you don't want to put the pad directly over the pacemaker. Same thing with an automatic internal cardiac defibrillator. There are people out there with severe heart disease that are prone or suspected to be prone to going into sudden cardiac arrest. So the cardiologists prophylactically implant this device. Sometimes they're implanted with pacemakers as well, and that's quite often the case. That senses the intrinsic rhythm of the heart, and when it detects an arrhythmia or detects a ventricular fibrillation or VTAC, it'll automatically deliver a shock to reset the heart. But a lot less energy setting than your external defibrillator because it's already directly wired to the heart. It doesn't have to go through the thoracic wall. But the patient will feel it. The patient will feel it. You would not feel it. If you were taking a blood pressure on this patient, or if you were assessing or listening to lung sounds and that defibrillator went off, you would not feel the electrical jolt because it's just not that strong. The patient will feel it. They'll feel like they got hit in the chest with a sledgehammer. So it's nothing for you to worry about as far as safety goes, unless your patient swings his hand at you from the pain of the shock. But don't be surprised if somebody knocks on your window and says, "Can you take me to the hospital? My defibrillator went off." Don't look at him like he's got 6 heads. What's relatively recent and up and coming is a device called a left ventricular assist device. This is about as close to an artificial heart as we have besides an artificial heart, which are not that common. A left ventricular assist device basically takes over the job of the left ventricle. This is for somebody who has a really, really weak heart and is on the waiting list for a transplant. But this device will buy this person time until they can get that transplant. It's a mechanized device, and I think I put a video on your in your learning folder about it that just reroutes between the left ventricle and the aorta, and it does the job of the heart. It physically moves blood through the circulatory system. Now, there's a couple of issues with this. How do we measure cardiac output at the EMT level? Well, we do it by assessing a pulse and assessing blood pressure, a pulsatile flow. Um, a lot of times these machines give a continuous flow of blood through the circulatory system. They don't pump, they generate a rotor, which constantly just moves the blood at a constant rate. So a patient with a left ventricular assist device will actually not have a palpable pulse. Interesting. They will not really be able to detect a blood pressure. So it's recommended that don't even bother. Just document on your paperwork that left ventricular assist device. Now, here's the debate and the controversy. Okay, so this thing is directly hooked up and sewn to the aorta. What happens if this person becomes unresponsive and we presume cardiac arrest? Do we do CPR? Is CPR necessary if this machine is still moving the blood? Well, at the BLS level, there's actually not a very good answer. At the ALS level, there's things we can do to determine if this is truly cardiac arrest. At the BLS level, it's tough. When these devices initially came on the market, the suggestion was do not do CPR, because if you do CPR, you can potentially cause the tube to rip out of the aorta, and God knows the person will bleed out and have no chance of survival at all. So this is tough. First thing you want to do when you assess this patient, is obviously from the ABCs, is try to see if that machine's working. Do you hear it humming? Is the motor charging? Are the lights on? If the machine is humming, then it's very likely that it's moving blood, in which case you want to obviously support ventilation, support the airway, and get them to the hospital as quickly as possible. Not every hospital uh, is equipped to handle patients with LVADs. So that's another interesting mess or jam you might go into. Patient's family may insist that he goes to a particular hospital because that's where everything's been hooked up with their LVAD, but that hospital may be ways far away from the nearest 911. And what are the other reasons that this person may be unconscious? Also, you got to think about that too. Are they hypoglycemic? Are they having a stroke? Are they having some kidney shutdown? Did they have a seizure? Just some things. They have head trauma. There's things that come to mind. So you have your work cut out for you when you confront this situation. They're very interesting devices, though. A lot of times, and again, I didn't really understand this when I first saw it, people will have feeding tubes surgically implanted into their GI tract for whatever reason. They maybe have underdeveloped palates. They may not be able to orally take food without the risk of aspiration. It's usually common with a lot of congenital abnormalities. So they have to have food fed to them in a pump. And usually it could either be pumped in or it could be delivered in. Now, a lot of times you'll wind up getting a call to these patients because that tube, that what they call J tube or feeding tube, became dislodged. Now, it's not within our standard of care to uh, reinsert it in. They do that in the emergency room, but you should be familiar with it. So if it's been dislodged, then you just want to cover that area with a dressing, tape it up, gently take the person to the hospital. It's not an acute emergency, but it has to be addressed. Another reason why you may get called for one of these jobs is that because it gets clogged, which can happen if it's not flushed properly. And if it gets clogged, then again, just cover it up with this. Don't try to dislodge it yourself. Don't try to flush anything in it, just because you don't know if the obstruction is actually in the tube itself or if it's somewhere in the digestive system. So basically, you would just want to cover it up with some dressings, transport them as appropriate. Another issue that may occur with these feeding tubes is if they're overfed, and this could be a problem. This little one looks pretty bright and alert and developed, can probably communicate any problems as needed. Some people with these devices cannot. And if they're overfed through this tube, sometimes they can wind up regurgitating and aspirating down into the lungs, and then you've got a very, very sick patient. So just keep that in mind. Quite often, you'll wind up transporting somebody who has a Foley catheter, a bag that has a tube that inserts into the urethra and constantly drains urine out of the renal system. And the reason for this could be they may have lost all control of their bladder muscles and are constantly incontinent, in which case that sets them up for things like skin infections and urinary tract infections, or they may be recovering from surgery or for a number of different reasons. The big mistake that's made with these things is that when you transport a patient, this should be emptied out prior to initiating transport. Package your patient. Now, what a lot of EMTs and even paramedics do is they'll put the patient down on the stretcher, they'll wrap them up in sheets, they'll empty the Foley bag, and then they'll leave the Foley bag on top of the patient until they get to their destination. Well, the problem with that is this bag needs to be lower than the excuse me, than the patient's bladder to allow it to drain. It needs gravity to work. If that bag is placed up on top of the patient, that urine has nowhere to drain, it has nowhere to go. And so it backs up. It backs up into the bladder, it backs up into the kidneys, and a 30-minute transport time, uh, interfacility transport, could put this person into acute renal failure due to backup of urine. So understand that, and please, well, once you've got that patient transported and packaged up and into the ambulance, unravel them, unwrap them, and stick this thing down, not on the floor, but on the lower end of the stretcher. There's plenty of places you can hook it up to allow that urine to drain. Another thing you may wind up seeing out there that may freak you out is a colostomy bag. The first time I ever saw one for real was early in my EMS career, and the call came in as a stabbing. A stabbing? What the hell? Yeah, well, what happened was on the other west side of Manhattan, the police had they they were just addressing this homeless guy or some guy on the street for one reason. He flagged them down for help, and he showed them that his colostomy bag fell off, and they didn't know what was going on. They said it looked like he got stabbed, and somehow the message got over the dispatch radio that was a stabbing. No, what a colostomy is a rerouting of either the small intestine or the large intestine. So it's introduced outside of the abdominal wall. So for whatever reason, maybe this person had colon surgery or colon cancer or had an acute obstruction, and or they had such bad colon disease that part of that colon had to be removed for whatever reason, that they had to remove the lower part of the intestine, and for elimination they had to surgically reroute the intestine outside and make an opening in the abdominal wall so they could eliminate the fecal material. Now what usually covers up that opening is a colostomy bag, which can be attached and detached to this mounting mechanism that's sutured in place. Common problems usually include things like infection, blockage, or dislodgement. Um, this is actually kind of gross thing to deal with because this is all very liquidy, malformed fecal material that didn't really get the chance to get its final processing through the terminal end of the colon. So it's usually pretty messy. I hate to tell you that, but you still got to get through it one way or the other. So Danny talked a little bit about dialysis a couple of weeks ago. And as you know, most patients who are on hemodialysis get access to the vasculature through what's called an AV fistula or a graft. They do one of two things. They either reroute and attach the artery to the vein, and they actually dilate it and expand it so they can access the vasculature. But it takes time to do that. So here's the thing, is that you don't ever want to take a blood pressure on this arm if they have a graft or a fistula, because you could wind up causing severe damage and severe bleeding or disruption of the fistula itself. If these things burst or bleed, or if there's any trauma to that area, this thing will bleed like crazy. And you're going to have to really employ all your trauma skills to stop that bleeding. And then finally, the other last device you see, some of you have probably been in an emergency room and had a peripheral IV placed in. We've seen paramedics do that so they could get access to the vasculature and give medications or fluids. And those peripheral IVs that you get in the uh, ER are only good for about 24 hours, and then they have to be changed. And hopefully they don't have to be changed that much. Hopefully your hospital stay is very short. Sometimes people have conditions where they have to have access to the vasculature for a prolonged period of time. Say they need chemotherapy or long-term IV antibiotic therapy for things like bone infections, osteomyelitis. They could be on antibiotics for weeks, and infused antibiotics. Can't just keep putting in new IV every day. They'll have no more veins. So you have deeper veins like central and PICC lines, which are surgically implanted deep into the venous system underneath the muscles, and they usually route them almost really close to the heart. And these are designed to stay in place for a certain amount of time, for at least a week or two. Um, a problem like anything that enters the body that shouldn't is always a problem with infection. And what are signs of infection? Redness, swelling, tenderness around the site, leakage of pus. That's always a possibility, even if they're on antibiotics. These things can also clot, in which case infusion will not go through and it'll need to be replaced. Or it could be inadvertently dislodged, in which case you might notice some bleeding going on as well. Uh, I don't think I really have to tell you what to do. Obviously, if it's partially dislodged, do not complete the dislodgement. Cover it up, bandage it, and proceed to the nearest emergency room. You may be called to transport somebody um, for a completely unrelated condition that has this IV in place. Well, if IV in place is theoretically an ALS job. So if they have something being infused actively through that port, you cannot transport, at least not in New York State. So you could do one of two things. You could call for ALS backup, and they'll love you for that. Or you can ask the caregiver if they can discontinue the infusion and then cover this up with a sterile trauma dressing, make sure it's not exposed, and then you're perfectly appropriate to transport at the BLS level. If they're not willing to discontinue the infusion, then you have to call for ALS backup. And so with that, let's just recap a couple of things we covered. So what is the purpose of a tracheostomy in an ill patient? And that would be to assist the patient with their breathing, one way, shape, or form, or the other. Which of the following is true in regards in touching a patient who's being shocked with an AICD? The EMT cannot feel the shock of an AICD when delivered to the patient. Obesity increases the risk for which of the following health problems? Uh, Basically all of them. Liver disease, type liver disease. You can get fatty infiltrates in the liver and increased liver enzymes. Type 2 diabetes and respiratory problems. During transport, where should the catheter bag be after loading the patient and stretcher into the ambulance if the patient has an indwelling urinary catheter? That should be lower than the patient, but not on the floor. Which of the following situations are frequently problematic for patients who have tracheostomy tubes? Most often, that is the mucus buildup. And with that, that is the end of tonight's presentation. I will stick around for questions and autographs.